Hi, I'm Anthony Ghosh, consultant neurosurgeon and founder of the Spine MDT, and this video is about same-day spinal surgery or day case spinal surgery, or sometimes known as outpatient spinal surgery, which operations are suitable for that, and my thoughts on it. There's a big commercial drive around minimally invasive spinal surgery and also day case spinal surgery because it sounds amazing. Quick procedure, in and out of hospital the same day, quick recovery. Whilst in our practice at the Spine MDT we try and find the least invasive procedure that gives the longest lasting result, that doesn't always mean being discharged as quickly as possible the same day is what's best for the patient. Now, there are benefits to the patient of being discharged the same day, getting home into your own environment as quickly as possible, but also have to remember there are benefits to the hospitals and in some countries to the insurers. There's reduced costs to keeping a patient in overnight. There are some variations in practice between surgeons, so today I'm going to tell you mine and why. So firstly, let's talk about the injections to the spine. I've done a video on this, which I'll give you a link below. So for slip disc, as we see here, front of the spine, back of the spine, these are the bones that make up the spine. These are the cushions between the bones called the discs, which can herniate. They're soft pieces of tissue that can herniate and pinch nerves. One treatment for these is what is called a transforaminal nerve block, which is a type of injection where you pass a needle through the skin of the back under light sedation and you inject some steroid around this. And the theory behind it is it takes down the inflammation caused by the nerve compression, whilst at the same time your body tries to break down this disc fragment. This is carried out under light sedation, so that's very low risk in itself. And then passing a needle through the skin of the back again, it's a very low risk procedure. This is done as a day case with very little risk of anything going wrong that same day. Talk about actual operations. So let's say the same scenario, a slip disc here is pinching a nerve. It's either failed an injection, or there are other indications where you might need an operation called a microdiscectomy to shave away this disc fragment here and release the nerve. That requires an incision through the small of the back, a small window under the microscope in this arch at the back of the spine, and then removal of this fragment. It's done for a very small incision. Patients are up and about immediately after the surgery, and you can theoretically go home the same day. Now, with most operations, my practice is a bit different. I do prefer patients to have just one night in hospital. Whilst you're up and about the very same day, day one, you find that you've still got some anesthesia circulating in your body, some local anesthetic in the wound of the, in the wound of the back, and I just want the physiotherapist to have a thorough assessment of you before going home. And I usually find that's usually better or more achievable the following morning. Whilst you've still got the anesthetic in your system, you're quite tired from the surgery. Taking it all in and just having that education, I think is really valuable. So doing that the very next day, I think is better. The exceptions are if you're undergoing this surgery in my practice first thing in the morning, at the very start of the day, you're first on my list. It's not unreasonable to go home towards the end of, towards later in the afternoon. By that point, all the drugs are out of your system. If the physiotherapists have seen you, given you everything on an information sheet, that's usually okay. The other reason I like patients to stay overnight is some of the early potential complications, specifically any bleeding in the area causing enough of a blood clot, a hematoma, to compress the nerves. It just gives you that extra bit of time so that I can identify that. It's a very rare complication, and I'm mostly treating myself in a way, but it just gives me that reassurance that when you do go home, we're kind of outside of the danger zone for that complication. Another scenario is the same condition, a slip disc, a disc herniation causing nerve pain down the leg. If the disc on the scan looks like it's relatively soft, and that's something you kind of have to judge clinically and with your interpretation of the scan, and the disc is very lateral, sitting in this area here, This can be accessed through an endoscopic spinal surgery approach, which is made for a much smaller incision in the skin. It's done under sedation, and a thin endoscope, just for a little puncture wound in the skin, can come in from the side and just pull out that fragment. In that scenario, it's usually okay to go home the same day because, as mentioned, it's sedation as opposed to full-on anesthesia. If the physios can see you the same day and give the information, that's usually okay. Another minimally invasive procedure is a posterior lumbar decompression through a minimally invasive approach. This is for spinal stenosis. This is focal narrowing of the spinal canal, so front of the spine, back of the spine, and then you get a combination of a bit of a disc bulge, but mostly thickened joints and ligaments at the back of the spine, almost calluses that form as we get a bit older. You get this focal narrowing where all the nerves get a bit pinched. And the procedure I do for that is a minimally invasive decompression. This picture is not quite what I do, but it's through the midline of tiny nick in the skin, these special retractors that go in. Again, you make a little window at the back of the spine and you undercut some of that thickened ligament and overgrown bone to create more space in the spine. That's another minimally invasive procedure where I get patients up and about the same day. Again, if it's carried out first thing in the morning, where if a lot of the drugs are out of your system by later in the day, the physiotherapists have seen you and everyone's happy, then at that time a good few hours have passed, so we're outside of that risk of a hematoma, or bleeding, compressing the nerves, and I'm usually okay with you to go home sort of end of the day. However, any later than that, I generally feel a bit more comfortable you going home the next day. Because as mentioned, I've got a bit more time for you to be observed. You'll still be up and about, you'll still be walking around, but I've just got a little bit more time to observe you for any sort of slightly delayed complications. I find the next morning when the physiotherapists work with you, you're that little bit more brighter, you're able to take it in, remember it, and patients generally just feel a lot better doing it that way. Finally, I want to talk about a minimally invasive lumbar interbody fusion. This is where commercially there is a bit of a drive to try and turn this into a day case procedure. A lot of progress has been made in making fusion of the spine less invasive, i.e. getting to the target and doing the job beneath the skin through a less invasive approach, which I agree with in terms of your recovery and soft tissue damage. But in terms of your stay in the facility where you're having this done, I'm personally against sending patients home the same day, even if I do get them up the same day, which I always do. I just like them to stay in just one night so I can observe them. I think this is a much bigger operation than the microdiscectomy or a posterior lumbar decompression. Even when these are done through an endoscope and through small, tiny incisions in the skin, what's going on beneath is still quite significant, and I think there is potential for complications that we need to be aware of. So just to be clear, with this operation, this is the front of the spine on an x-ray, the back of the spine, and here we can see the segment has been fused with this little breeze block, a cage that's been placed between the two bones, and a construct of screws that kind of holds it all together. If we do a cross section of the spine, so this is the back, the front, and therefore right and left, again through a tiny incision, you come in under the microscope and remove all of this disc here, and in its place you put in this special sort of breeze block and bone graft and stuff in between the two bones to allow them to fuse, and then you put a construct of screws and rods in at the back to hold it all together. So whilst it's a minimally invasive procedure in terms of the incisions are very small, there's not a lot of tissue disruption, what goes on underneath is actually quite major, and I just want to keep patients for at least one night in hospital, sometimes two even, just to really give you a good opportunity for the physiotherapist to work with you. A lot of the recovery from this and a lot of the treatment isn't just the surgery, that's just part of the treatment. And thereafter there's the physiotherapy, the exercises you do, and the rehabilitation. I just think you need a little bit more time to get the education behind of all of that to get a good recovery. And it also gives me a chance as a surgeon to really watch you and make sure that no complications are occurring, any bleeding or anything like that we can deal with whilst you're an inpatient. I've left some links below to other videos I've done on these different procedures that I've described. If you found this video helpful, please click the like button and subscribe to the channel. It really helps patients suffering with back pain or spine disease find information I try and post on this channel. And please feel free to visit us at spinemdt.com to see how we can help you. Thank you.